We're taking this, 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 we're taking with a pinch of salt.
Welcome back to A Pinch of Salt, the official ERA podcast. My name is Hugo Diniz. I am an interventional nephrologist from Porto, and I am your new podcast host. Today we have a great episode about IgA nephropathy, a disease where for decades nephrologists become very good at looking thoughtful while saying, let's optimize supportive care and monitor closely, which translated into plain English most of the time meant there is not really nothing else to do. But fortunately, the landscape has changed very quickly. We now have SGLT2 inhibitors, endothelin receptor antagonists, maybe even non-steroidal MRAs. Let's see these new findings in the Glasgow ERA Congress. And also more targeted therapies like targeted release budesonide, complement inhibitors, and the focus of this episode, therapies targeting APRIL and BAFF. So now we have the opposite problem. We've gone from one road to really a therapeutic roundabout with several exits, and really nobody wants to take the wrong one. And we even have new KDIGO guidelines that really try to make sense of this new era by asking to treat both the immune disease, but also to not forget the ongoing CKD. I know this sounds very elegant on paper, but we clinicians have this special talent for destroying beautiful diagrams. So to help us navigate this uncharted waters, I'm delighted to welcome Professor Vlado Perkovic. Vlado doesn't really need an introduction, but I guess I'll have to do it anyway for those who might be living under a rock or something. So he is a nephrologist, a clinical trialist, a provost and scientia professor at the University of New South Wales in Sydney. He is also an honorary fellow of the George Institute for Global Health Australia and led many practice-changing clinical trials in diabetic kidney disease and IgA nephropathy, such as Credence, Flow, and Testing. He is actively involved in the programs that are shaping the future of IgA nephropathy. So if there is someone who can help us separate evidence from excitement and hype from hope, it is Vlado. Vlado, welcome to A Pinch of Salt.
Thanks so much, Hugo. It's great to be here with you, and I'm delighted to have received the invitation. So I look forward to the conversation.
Yeah, thanks so much. And let's just start with the big picture. IgA nephropathy has been with us since Jean Berger described it in the late 60s, but it really feels that we've made more progress in the last 5 years than in the previous 50. So what really changed? Was there a single breakthrough that opened these floodgates, or was just this a slow build that the nephrology community wasn't just paying enough attention to?
Yeah, it's an exciting time, isn't it, Hugo? It's been amazing to see just how quickly things have changed, really, in the last 5 years, and how far we've come. I gave a talk on IgA nephropathy a year or two ago in Australia at a weekend congress where the organisers told me that just 3 or 4 years ago, they had proposed having a debate about whether we should treat IgA nephropathy at all, and how far we've come from that conversation. And isn't it wonderful that we've done that? I don't think there's a single factor that's really moved us forward. I think there are several. I'm happy to go through those, but a couple of them were particularly important. I think fundamentally, one of the key things is that we've developed a really much better understanding of how and why IgA nephropathy develops and how it causes kidney disease, and the role of galactose-deficient IgA, the role of autoantibodies, the role of complement, and the role of the maladaptive responses in the kidney, and their importance in the progression of IgA nephropathy. That's been foundational, and without that understanding, we wouldn't have known, I think, which treatments to test. But that in and of itself wasn't enough. I think we also learned that we could actually do proper large-scale trials in this area. You mentioned the testing trial earlier. We began that trial in 2012, and at that point, the largest completed randomized trial in IgA nephropathy had randomized about 80 participants. And all the IgA nephropathy trials that had ever been done had randomized a total of about 500 participants. And that's, of course, now roughly our standard size for many of the newer trials that are ongoing. So building the capacity to run these sort of trials across the community, I think, was an additionally important step. Probably the single most important step, though, was the leadership of people like Eliza Thompson at the FDA, working with the Kidney Health Initiative, a range of other people in the area, and pulling together data that demonstrated the strength of the relationship between proteinuria in particular and kidney failure ultimately. And that really allowed the regulatory agencies led by the FDA to move to a position where proteinuria could be accepted as a reasonably likely surrogate for which accelerated approval for new drugs could be granted. And developing that pathway was critical because it gave many people in industry, in biotech, the confidence to know that if they invested in treatments for IgA nephropathy, there was a clear and relatively short path to market for them that would allow them to start making some of that money back. And that, I think, has been the critical thing that opened the floodgates to the barrage of investment in new treatments for IgA nephropathy. That was absolutely critical. And, amongst many other factors that I could list, the other one I think I'll just mention here is, of course, the radar data and other longitudinal prognostic data. So that told us that actually this was a much, I think, worse condition, a much more morbid condition that led to much higher rates of kidney failure than we had anticipated to that date, where we treated people with low-level proteinuria as having a relatively benign course, and we learned from radar and other data that actually wasn't true, that even people who had less than a gram of proteinuria developed kidney failure in the majority of cases over 10 to 15 years. And given that these are young people, that was critically important. So all of these factors, I think, contributed and have led us to a much better and much happier place. And it highlights, I think, the importance of basic science, of epidemiology, of high quality clinical trials, and then consolidating all of that into an evidence base, which is where I think we've got to now.
Yeah, thank you so much for your detailed explanation, but it really does make sense from a regulatory standpoint that these usually are much younger patients than our usual CKD patients. So even if they are at a high absolute risk of developing kidney failure, if we would need really hard endpoints like kidney events, it would take much longer to run these trials, and they would be very cumbersome to do and very expensive. And you mentioned proteinuria, and I think if you agree, the eGFR slope is also being accepted as a proper endpoint of these trials is also very meaningful, right? And it also for clinicians very easy to understand. Like the rate of decline is progressing much slower. And so this all of this really converged into these new KDIGO guidelines, and I think the new framework is very interesting. But because, as you mentioned, from the radar, that even people with benign disease are an absolute risk of bad outcomes. So we can't look at the IgA as a single problem. We need to treat both the immune drivers of the disease, but also the downstream CKD consequences, blood pressure, nephron loss, cardiovascular risk, all of that. And this is wonderful, of course. It's very beautiful in the paper, and they bring clarity, some structure, and even some panic when we realize that we have not quite caught up to them. But in practice, we still need to decide who needs immune-directed treatment and who can be still, at least at first, be managed with optimized nephroprotection. I think this is an area of very much debate around nowadays. I don't know, because there are really different schools of thought now. And I mean, we used proteinuria as kind of our weather forecast for years. It's useful. I mean, very useful, and it's a good marker. But sometimes you still get sprained on, I guess. And really, some experts really think that we need rethink completely our approach to IgA nephropathy. And we have very vocal voices from, for example, Mayo Clinic, that we need to look more into hematuria as a marker of active glomerular inflammation, for example. So, what do you think? Do you think proteinuria alone is still enough to guide treatment decisions in IgA nephropathy for patients that need immunosuppression or immune targeted therapy, or we need to rechange how we think about this?
An important question, Hugo, and I think we need to understand why we've chosen proteinuria as the main focus to date. I mean, it's a really strong predictor. It's perhaps the strongest predictor of outcome if we choose a single factor. And the question is, do we need to choose a single factor? That was important in helping us design and run trials that were implementable, where it wasn't too complicated effectively, because we really didn't have other valuable tools, and it remains an incredibly useful tool and an important tool in people who have elevated proteinuria. But in people who have more modest elevations of proteinuria, even in the radar data, the majority of those patients who had less than a gram of proteinuria per day, for example, developed kidney failure over a long period of time. And that tells us that amongst that group, perhaps there's value in us developing a more sophisticated methodology to help us identify those people, particularly who don't need some of these more invasive and intensive therapies. And that would involve markers like hematuria that may or may not be useful. I don't think I've seen compelling data that answers that question at this stage. Or the other approach, of course, is that we could use risk scores, as we're using in other parts of nephrology, as has been used in cardiovascular disease and elsewhere for decades. And I'm really attracted to that sort of approach because it allows us to integrate not just proteinuria and hematuria, but other clinical biopsy, etc., factors that we can then use to understand what someone's risk is and the intensity of therapy that might be appropriate. I think it's also important to recognize that most of the people who've been involved in the trials at this stage have very high levels of proteinuria and are therefore at incredibly high risk. And we've seen that reflected in the rapid rates of loss of kidney function in placebo trials to date.
So is there a particular risk score you would recommend at this point in time? Anything that is clinically validated?
I think we're still at a relatively early stage in terms of risk scores. I think there's some great work coming out of Canada that is looking very promising in this area, both in general CKD, but also specific to IgA nephropathy. And I think I think that is an important research focus for us moving forward. But I'm not sure we're quite there yet, based on the data that I've seen.
Yeah, it does make sense to integrate all these important markers, not just relying on one to make our calls. And there is really a lot of excitement now around these new therapies targeting both APRIL and BAFF, or even both. We're talking about sibeprenlimab, or SIBI for shorts, or atacicept, or telitacicept, and others. The goal, if I understand correctly, is of these therapies is to reduce the production of galactose deficient IgA1, which takes us much closer to the root of the disease. And this feels very different from just reducing proteinuria downstream at glomerular level. I know we still don't have the full eGFR slope data, but it really feels that this class of drugs may be changing the engine of the disease, and might even explain why Professor John Barrett is now provocatively calling RAS blockade and SGLT2 inhibitors palliative care in IgA nephropathy. So how do you see these therapies fitting in the treatment algorithm in the future from all the data that you've seen in the clinical trials so far? Maybe even frontline therapy, more like maintenance therapy, rescue, or a mix, something else entirely? What do you think at this point in time?
Yeah, they're exciting treatments, but before I say that, I think John's a bit naughty calling it palliative care. He likes to be a troublemaker and to be provocative, as you say. And it's a useful provocation for us because it makes us think about what we're doing with these therapies. But we should
Mhm.
remember that these, RAS inhibitors, SGLT2 inhibitors, endothelin antagonists are all agents that, for which there's data suggesting significant kidney protection. It's not just symptomatic management, it's
Yeah.
keeping people off dialysis. So I like to push back on John for
Mhm.
many of his provocations, and that's one of them. But the B cell therapies, of course, are incredibly intellectually appealing because they directly address um, the cause of IgA nephropathy as we currently understand it. As you say, the production of galactose deficient IgA, perhaps also the IgG autoantibodies that
Mhm.
form the immune complexes. And by reducing both of those, we can reduce the number of immune complexes and therefore the factor that drives the injury in the kidney completely upstream. And that is very attractive and might be expected to be amongst the most effective therapies. And of course, that's what the data to date is suggesting to
Mhm.
us, that these drugs are profoundly effective at reducing proteinuria, more so perhaps than any other treatment that we've seen to date. And I think, if the data on EGFR matches that and marries with the proteinuria data. And the only EGFR data that's been reported to date was the telitacicept in the trial in data from a trial in China, where at 9 months there was a profound slowing in the rate of loss of kidney function. If that is borne out with these other agents, I expect these drugs would have an important foundational role in IgA nephropathy. They would be, really intellectually, that feels like they're the most appropriate starting therapy. And presuming, of course, that we can afford them, and that's a
Mhm.
whole nother
Yeah.
story, and
Yeah.
presuming that they're safe. And we
Yeah.
don't have adequate data to know the answer to that question yet. But what we've seen so far looks incredibly promising and suggests that these, might be, perhaps the most important therapy in IgA nephropathy. But we need to see what the data shows.
Yeah. And I think that really leads beautifully to our next question, is to detail a bit more the actual trial data from Visionary and Sibeprenlimab. So we saw, as you mentioned, a massive reduction in proteinuria, roughly 50%, if I remember correctly. And I think that's already impressive. And also for me, the interesting part is also this significant reduction in galactose deficient IgA1. So it really acts as expected by about 70%, and also the total IgA by about 70% as well. And we also see reduction in IgG and IgM. So I think this kind of convinces that um, it's generally modifying the biology of IgA nephropathy. And is there anything else from the data that do you also think that or leads you to believe that it really addressing the root cause of the disease besides proteinuria?
Yeah, look, I think the the factors you've highlighted, the reduction in IgA overall and in galactose deficient IgA1, can give us comfort that these drugs are acting through the sort of mechanism that we expect them to act through. And I'm really impressed by the proteinuria data. I have to say I wasn't. If you asked me whether we'd ever see individual drugs that can lower proteinuria by more than half, I would have been skeptical a few years ago. But that's what we're seeing, not just with sibeprenlimab, but also with some of the other agents in the class. And that magnitude of proteinuria reduction is incredibly promising, married with that immunoglobulin data in terms of what we might expect moving forward. But, of course, there's the other side of that coin. Those dramatic reductions in IgA are also, you know, mirrored by reductions in IgM, and lesser but still important reductions in IgG. And we've got to make sure that the ultimate safety of these agents is what we expect. We've seen drugs like corticosteroids, which turned out to be very effective at
Mm-hmm.
protecting kidney function in IgA nephropathy, but also turned out to increase the risk of serious infections, causing death in a number of people. And that, the idea here is if we can be much more specific and targeted with our treatment approach, that perhaps we can get those benefits, but without the same increased risk, hopefully with much reduced risks of adverse events. And the other bit that's been really impressive to me has been the safety data that we've seen so far from the agents across the class that have reported that data. We haven't seen any increase in the risk of infections or serious infections. We've seen no deaths. It's early days yet. We need the long-term 2-year data, but that will come over the next year or two. And I'm really optimistic and hopeful about what we might see with this class of agents.
Yeah, I think you touch a very important point because since we are turning a fairly important part of the immune system is to ensure that these are safe, especially if we might have to give them to patients over a long period of time. And you mentioned other drugs in the class have a similar profile to sibeprenlimab. The other major B-cell therapy already have data is atacicept, and it's a bit different because it blocks both APRIL and BAFF. But the results are at least clinically similar in Origin 3. It reduced proteinuria about 50% also at 9 months. And the biomarker story, again, is striking. We have a reduction in IgA, galactose deficient IgA1, total IgA, IgM, IgG with a similar pattern of CB. And but based on the current phase 3 data, is there any meaningful way to choose or to think about this difference between APRIL inhibition and the dual APRIL-BAFF blockade?
I'm not sure that we're able to do that yet, Hugo. I think the hypothesis that dual blockade will lead to more complete reductions in immunoglobulins, more complete B cell inhibition, and ultimately better outcomes is not yet supported by the data. As you say, the effect on the intermediate biomarkers, the immunoglobulin levels look consistent, not just between sibeprenlimab and atacicept, but also with telitacicept and povetacicept, as well as zigakibart,
Yeah.
other drugs in the class. We've seen broad consistency across those, but the data that we've got so far is still relatively short term. It will be really interesting when we start to get the 2-year data over coming months to see not only whether the effects on kidney function are consistent or not, whether one
Mm-hmm.
or other class or approach is superior from that point of view, but also whether there are differences in safety. So ultimately, I think the data will tell the story, and we don't yet have enough data to answer that.
Okay. And if I'm allowed to speculate a little bit, maybe one will develop less auto antibodies against the proteins or the antibody itself, and maybe that's relevant or in the long-term management of disease. Have we
I think
seen
that's
with
an
other
important
biological treatments? Yeah.
Yeah, Hugo, that's an important additional point,
Mm-hmm.
whether these drugs' effect will be sustained over time and what sustained effects means will be important. At the 9-month mark, proteinuria levels were still falling, but
Mm-hmm.
so were immunoglobulin levels, albeit at a much slower rate than they were early on in the trial.
Yeah.
We need to have a look at what happens to all of these markers, both intermediate and the ultimate clinical outcomes over the entirety of the period of the trial to understand both whether there are differences in efficacy that occur as a result of the mechanism, as a result of the development of autoantibodies or other factors, but also whether those things have an impact on safety. There are other elements that really haven't been talked about much, which are things like the dosing regimen. Some of these drugs have a consistent dosing regimen across the entire 2-year period. Others have effectively an induction and maintenance type approach. And what the right approach for us is going to be, if we're talking about using these drugs not just for 2 years, but potentially for many years or even decades in our patients with IgA nephropathy is going to need a lot more study moving forward.
Yeah, I mean, if we are talking about really switching off or at least turning down this pathogenic IgA production at the source, we might be discussing a really potential clinical remission is on the table. And are you now more confident about this that when you gave your plenary lecture at the ISN, the Yes We Can Cure Kidney Disease?
Look, I'm getting more confident over time, but um, I'll be much clearer when we have more data. I think one of the things we have to remember is that we really have targeted the very, very severe end of the IgA nephropathy spectrum. The majority of the patients in our trials have had, an average of 1.5 to 2 grams of proteinuria per day. So even with a 50% reduction, we're still getting that down to sort of 3/4 to a gram a day. And these people may well remain at high risk at that level. So these drugs, I think, will be incredibly powerful. I think for people with lower levels of proteinuria, they may well be enough. I think for many other individuals who start off with high levels of proteinuria or develop high levels of proteinuria, we may need combination therapy. And I think that's going to be really important, not just the use of SGLT2 inhibitors, endothelin antagonists, RAS inhibitors, and perhaps B-cell therapies. But the question moving forward will be whether other agents in other classes of drugs perhaps should also be considered in combination or in sequence. What the right approach to using these drugs in people with IgA nephropathy, I think, are going to be important questions over the next few years.
Yeah, totally agree. And I know that our focus today is B cell therapies, but we can't really ignore also the recent data from complement inhibition and the applause again to your data of iptacopan that you recently presented in Yokohama with the simultaneous publication was also striking. I mean, there was a substantially slowing of eGFR decline compared to placebo, and I think this signal was much stronger than many people expected from this class of drugs. And this raises several questions, some mechanistic, other related to also long-term follow-up, duration, combination treatments. Well, as someone is deeply involved in the field, what really surprised you the most about the iptacopan data?
Yeah, look, the iptacopan data really did impress me and surprised me, to be honest. When we started the applause trial, I was hopeful that the drug would be effective, but I wouldn't have expected it to be as effective as it was. Roughly a 40% reduction in proteinuria, married to a slowing of eGFR slope from 6 to 3 mils per minute, a 50% reduction, and a 43% reduction in the sort of composite clinical endpoints, primarily driven by the 30% eGFR decline component. I mean, these are profoundly effective drugs, which in and of itself was a bit of a surprise. But the other thing that surprised me actually was the subgroup data, and particularly the fact that the drug seemed to be effective in every subgroup that we could test. So this, you know, has often been considered a potentially niche therapy for a subset of people with IgA nephropathy, but the data don't really support that. We don't yet have good data about various other immunological markers, for example, complement levels, and whether they predict outcome. That will be important. But the data at the moment suggests that really these agents are the iptacopan is likely to be effective in a broader range of people with IgA nephropathy, high-risk IgA nephropathy than we'd expected. And I think that suggests that it's going to be perhaps a more important treatment option than we had anticipated in IgA nephropathy, as long as it turns out to be affordable, which is a whole nother conversation.
Yeah. Yeah, that's always the issue. But yeah, I think what you mentioned that maybe the local activation of complement in IgA nephropathy is more clinically meaningful than we expected, and that might explain why it works in such a large portion of the patients that were involved in the clinical trial. And also related to this, do you think that we should, this is more like a technical clinical trial question, should we look at the 2-year EGFR slope in the same way for every drug? And to say that really a therapy is disease modifying IgA nephropathy. So is the same, so is it the same that we have the same reduction in EGFR decline with SGLT2 inhibitor or immunomodulator, for example?
Yeah, look, I think we could talk about this question for a long time as well. I think that drugs that slow EGFR decline are important, full stop. We shouldn't sort of walk away from that. That's a really important outcome, and when we show it to occur, we need to really take that very seriously as a marker of kidney protection. I think there are some complexities, though. I mean, we do see, for example, some drugs that have an acute effect on EGFR when they're first started, and then have a different effect subsequent to that. For example, SGLT2 inhibitors and RAS inhibitors, we've always known acutely reduce EGFR and then stabilize it. And that was always one of the sort of paradoxes that it took us a while to work through when we were running clinical trials of those agents. But with some of these newer therapies, the reverse is true. You know, with corticosteroids, and based on the telitacicept data that we saw at ASN, at least, perhaps some of these other classes of agents, we see an acute increase in EGFR early on, and then various rates of chronic decline. And I think it's important we consider those acute effects as well in understanding the long-term effects. I did a debate at the World Congress of Nephrology talking about iptacopan versus Nefecon, and it's at first glance the EGFR effects looked similar, but with Nefecon there was an acute increase in EGFR that was substantial, which meant that the long-term pattern looked a bit different. How important is that? I think we need to do some work to understand that, but I think we do need to look beyond the headline numbers to the pattern of EGFR decline and understand what that means.
Okay. So always look into the full context, not just using the same metric, like using the same metric for every drug in this, and also look at how they work for their mechanistic point of view. Okay. Unfortunately, we are going through the last bit of our episode, but I cannot let you go without asking the traditional question of our show. So, if you would happen to be stranded on a desert island, which book, 2 songs, and 1 luxury item would you take with you, and why?
This is a challenge, and I've spent quite a bit of time pondering it to think about how I would answer it. The book is difficult. I had to think about what's a book that would bring me pleasure, and I could read over and over again and enjoy. And the one that immediately came to mind, which always makes me laugh, regardless of how many times I read it, is The Hitchhiker's Guide to the Galaxy. So I would start perhaps with that book. Always some delights to be discovered in that. Which 2 songs? Again, if you had to listen to the same songs over and over again, which ones could you listen to? And whilst I might have been tempted to go with something R&B related or something more modern, I think ultimately, if I had to listen to the same song over and over again, it would have to be a couple of classical songs. And the 2 I would choose would be "Lack Me" by Delibes and probably Beethoven's Ninth Symphony. Ninth Symphony would be the 2.
Good.
And then the luxury item, presuming I'm not allowed something that will connect me to the internet, I would probably go with ideally a container or at least a crate of champagne, so that if I had to watch those sunsets, I've got some nice champagne to enjoy it with. And maybe
that's a good one. That's a good one. Yeah, it would make time go by faster, at least in the desert island as well. Okay, Vlado, thank you so much for being here with us. It was really a useful conversation. I think all our listeners are more enlightened now because IgA is becoming a lot more exciting, but also a lot more complicated. And this is usually how nephrology likes to keep us humble. And if we could wrap up, a key message is that we can no longer think of IgA nephropathy as the disease where we simply measure proteinuria, prescribe RAS blockade, and wait. And now we have to think in different layers or boxes, the immune activity, this complement activation, the glomerular and podocyte injury, but also the risk of CKD progression, the whole cardiovascular risk, and the whole patient phenotype and their life expectancy. So thank you so much, everyone, for listening to A Pinch of Salt. So if you enjoyed this episode, please like and subscribe in your favorite podcast channel, and maybe share it with a colleague and follow the ERA on social media for more nice and cool conversations like this one. So thank you so much, Vlado, and see you all next time.